Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Safely Home After Hip Replacement Every Time, presented by Dr. John Dearborn, orthopedic surgeon with Washington Hospital Institute for Joint Restoration and Research. Dr. Dearborn is an orthopedic surgeon and innovative joint replacement specialist who has been perfecting his art for over 30 years. He is a West Coast pioneer for joint replacement specialty centers, founding the Center for Joint Replacement at Washington Hospital in 1999. Now known as the Institute for Joint Restoration and Research, a comprehensive, multifaceted program that serves patients from all over the world. Over the past 5 years, Dr. Dearborn's rapid recovery protocols combined with less invasive surgical techniques have made same-day discharge following hip and knee replacement commonplace in the Bay Area. The IJRR program at Washington Hospital has won accolades throughout the West Coast. Please welcome Dr. John Dearborn.
Thank you for that very generous introduction and for the invitation to give this lecture. As always, I like to start my presentations with the goals up front so that we can be effective in achieving those. The first goal for today, if you're viewing this presentation, would be that you would understand how modern hip replacement surgery fits into the historical context, not just the procedure, but also the economical considerations. Second, we'd like you to be able to grasp 4 critical ingredients for a safe and smooth hip replacement experience, whether that procedure is performed at an ambulatory surgery center or at a hospital. And then lastly, when you leave the presentation, I'd love you to have increased confidence if you're considering same-day discharge from either a surgery center or a hospital. Who am I and why should you trust me? This will come up later in the talk as we're talking about trusting your healthcare providers and your system. But I've been a joint replacement specialist for over 27 years in practice. I trained at some good places. As mentioned before, I was fortunate enough to found with the hospital the Center for Joint Replacement, which is now called the Institute for Joint Restoration and Research. That program grew from 90 procedures per year to more than 2,000 procedures in 2023. And our program has been widely emulated for efficiency all over the Bay Area and beyond. So when you look at other programs in the Bay Area, they pretty much just copied us. And importantly, I don't have any industry conflicts that's going to sway my presentation and lead the audience in a particular direction. Our model works, and the testimony for that is great outcomes. Healthgrades likes to give accolades for great outcomes. And so for 12 years in a row, we've gotten their award that goes to the top 5% in the nation for joint replacement. And they've also given us their top designations for individually for hip replacement and for knee replacement. And now they have a rating for same-day discharge, and we have gotten their top rating for that as well. This is the regional draw of our program. So you can see we get patients from all over the West Coast. This little green triangle is Alameda County, which would be the normal drawing area of Washington Hospital. So you can see a lot of our patients come from elsewhere. To give you a total hip history in a very small nutshell, just for the sake of time, hip replacement started in 1960 in England with John Charnley there pictured on the left, which evolved from more primitive procedures which had been done previously. The length of stay for hip replacement at that time was between 2 to 4 weeks. Over the next 30 years, there were a number of implant improvements led by that man on the left, William Harris. And so by 30 years in, 1990, the length of stay average was down to about a week in the hospital. Over the last 35 years, there's been a lot of work on reducing the exposure and improving anesthesia, which has further reduced length of stay. Just to get you up to speed on hip replacement, when you're doing a hip replacement, what we're doing is resurfacing the joint by relining the inside of the socket and replacing the femoral head. So essentially, we're cutting the femoral neck and removing the head, relining the socket, and then putting an implant down inside the femur that has a new femoral head on it. So that's what a hip replacement is in a nutshell. Our experience with length of stay over my tenure of 27 years looks like this. It's a gradual decline. These are my average length of stay starting from 1998 at just under 5 days in the hospital to where we are in 2024 with an average length of stay of 0.3 days. Again, we're in this era where these improvements are being made by reduced exposure and anesthesia advances. So in the current era, how we do hip replacement is being driven by 4 primary market pressures. The first is that we're living longer, and the success of hip replacement means that every year we're going to do more and more hip replacements. This next chart shows the forecast of the number of hip and knee replacements that are going to be done in the United States over the next 20 years. Here we are in 2023, this last year, and we're doing about 500,000 hip replacements in 2023. And then if you fast forward to, let me go back to that, 2040, we're doing 4 times that many, about 2 million. So we're doing a lot. We're going to be doing a lot more cases, which is going to drive the market heavily. And so we'll get on to the next market pressure, which is direct-to-consumer marketing by implant companies, by the payers, and by surgeons to control the flow of what will be those 2 million hip replacements that we do in 2040. The companies, the implant companies that make those implants that we put in, they want market share, which means more money. The payers want cheaper hospitals in order to pay less money per case, and of course the surgeons will compete for patients. So it's about money, unfortunately. The rising employee and supply costs for hospitals means reduced profit margin per case, so there's pressure there on the hospital side. And then the payers, they're the ones who bear the added cost due to volume, so they're going to pass on that cost to consumers by raising your premiums. They're going to pressure surgeons to operate at cheaper places to save money, and those cheaper places may not be better places. And then they routinely audit us, and they retroactively deny payment, Medicare being the worst actor here. So there's a lot of pressure from the payers because they're paying the bills. So you look at those pressures, we've mentioned all 4 of those, none of them are in the best interest of the patient, which is sad. But that's the system that we're working in. How are we going to navigate these rushing waters? Well, we need to be focusing on cost containment, but without sacrificing quality. And you might ask yourself, is that even possible to do? Because normally when we're talking about containing costs, patients are worrying that we're going to be cutting quality in some way. So the quick answer to this is yes. How do you reduce cost? You reduce the length of stay in a hospital, or you have your surgery performed at an ambulatory surgery center that specializes in joint replacement. How do you measure the quality? Well, there's a lot of ways. You can look at patient mobility. How quickly patients can get up and move around is a surrogate for how well the operation was done. Patient-reported outcomes are very important and very popular these days. You can follow complication rates as well. If a particular facility is getting a lot of complications, maybe the quality isn't where it should be. You can look at readmission rates. In the current era, this is how we've answered the pressures. We've managed costs through appropriately shortening length of stay and shifting our healthy patients to an ambulatory care environment. And then we've minimized our complications through vigilance and enhanced patient education, and we'll walk through that during the rest of this presentation. How are we doing with that? Well, here's a graph that shows our length of stay since 1997. Which is in the greenish color, and then in blue, that's our complication rate. So we've been able to manage reducing length of stay and reducing complication rates at the same time. Having surgery at an ambulatory surgery center may well have advantages. There are several that have been built out in the literature, including reduced risk of infection, lower risk of other complications, improved efficiency, staffing issues, and a more relaxed and comfortable environment. I build out the argument for ambulatory surgery centers in a separate presentation, which can be found on our website at the URL at the bottom of your screen. So getting into the ingredients for a smooth process, there are primarily 4, and I list them here, and we're going to build all of these out. So first we should define what I mean by safe and smooth. By that I mean that your pain is under control, that you're not having any nuisances at the time of discharge like nausea or urinary retention. We want our patients mobile and safe on their feet. We want existing medical issues like heart problems or lung problems under control. We want the patients to have a solid backup plan in place. Contrast that with unsafe, pain poorly controlled, requiring a lot of medications. That's going to mean side effects for you. If you're not able to get safely on and off your bed, if you can't walk to the bathroom, you're going to be at risk for a fall, which will produce a complication, no doubt. If you have underlying health issues and those are exacerbated by the surgery, you may find yourself in an emergency room. If you leave the procedure and you head home alone with inadequate lifelines, that's also going to be a problem. So getting to the ingredients, first is the physician choice. I would advise seeing a hip specialist if you're going to have a hip replacement, because hip specialists are going to do more volume of that procedure, which usually means less problems. A less invasive method is important. Which one is probably not as important as doing it less invasively. Your surgeon should be trustworthy and wise. They'll help you navigate the choice between having it at an ambulatory surgery center versus the hospital, and they'll be able to point you to the right system to have your surgery done. A seasoned surgeon is very helpful because they will have seen complications and will know how to manage them. So that experienced physician will have a system that integrates patient selection, preoperative issues, anesthesia methods, surgery techniques, and post-surgery details all in one package. It's very important to get all of these together. So that surgeon will help you with your selection about surgery at an ambulatory surgery center versus a hospital, and may use information like what's found in this article, which looked at risk factors for complication readmission after same-day discharge arthroplasty. In that article, the authors emphasized that less healthy patients should have their surgery in hospitals. And by less healthy, we're talking about patients with poor nutrition, high BMI, low albumin levels, patients with breathing difficulties, patients who suffer from bleeding disorders, patients taking steroids chronically. There are other predictors of failed same-day discharge that were outlined in this article that came out last year in the Journal of Arthroplasty. Interestingly, age was not one of those predictive factors, but a late start certainly predicted a failure of same-day discharge, and patients having a lot of pain after the surgery also predicted a failed same-day discharge. So we'll talk a lot at the rest of this presentation about pain management. The surgery technique, what makes a difference? A lot of patients will ask about this. We know that less invasive techniques allow a quicker recovery. In our practice, we reduced our length of stay in 2001 when we adopted a less invasive approach to hip replacement. We reduced our length of stay from 3 days to 1 day. The surgery time was shorter and there was reduced blood loss with these techniques, which is going to improve the early outcome. What doesn't make a difference? Well, the main thing is where the incision is. If you put the incision on the front of the hip or if you put it on the side, there's no real difference. In fact, we looked at our data in 2022 and our mini posterior approach same-day discharge rate was actually slightly higher than the anterior approach same-day discharge rate. The use of robots and computer guidance also doesn't make any difference in terms of early outcome. So whether you put the incision there or if you put it there, doesn't seem to make much difference. If you want to read about these two approaches in more detail on our website at this URL on the bottom right on the page, there you can read all about the various issues and comparisons between anterior and mini posterior approach. New technology, the caveat there is it tends to be driven by industry and unfortunately marketed by physicians. If somebody is being paid to say that a product is good, be skeptical and wait for peer-reviewed data. Check also for industry conflicts via the Sunshine Act. There's a website at CMS, on the CMS site where you can look up different doctors and see what their conflicts might be that might bias them. The second ingredient for a smooth process is your preparation before surgery. Diet is very important. A balanced one, protein rich, will help with wound healing. Exercising, we call that prehab, before the surgery, helps with muscle tone and cardiovascular fitness. Work on both your arms and your legs because you'll need them both after the surgery. Check in with your primary care physician to optimize medical conditions that you may have. The third ingredient for a smooth process, I'm going to divide into 6 parts, and I'm calling it the secret sauce. This is what happens behind the scenes at the hospital or at the surgery center to make your process go smoothly. The first is preemptive pain medication and antiemetics, and we'll build each of these out separately. Second is how we're managing the bladder. The third is the anesthesia technique. Fourth is how we manage bleeding. The fifth is what we're doing in terms of reducing pain inside the wound by injection around the wound site. And the fourth I've lumped into post-surgery details. So let's walk through these. First of all, the preemptive medications. Before surgery, we want to give medications to manage the pain that's going to be produced with the surgery and that you'll experience after the surgery. The first is Celebrex and Tramadol. All of our patients get these medications. We also want to plan for the possibility of nausea, so all of our patients get intravenous Zofran, Reglan, and Decadron, which is a steroid that helps a lot with nausea. We also experience urinary retention in some of our patients, so all the men get a dose of Flomax. We also have our patients empty their bladder ahead of time, and we measure how much urine is left in the bladder after they go. We call that the post-void residual. We limit the use of intraoperative fluids so that the bladder doesn't get too full while the spinal is working. And third, we don't use urinary catheters because they tend to contribute to urinary irritation, retention, and possibly urinary tract infection even. The third part of the secret sauce is the anesthesia method. And I'm bringing up that article again from last year that looked at age and how that wasn't a factor. But here you see general anesthesia is a factor. Patients with general anesthesia had a statistically significantly higher rate of failed same-day discharge. And again, those pain scores are important. So getting into the anesthesia technique, we want to avoid general anesthesia. And why is that? Because the literature shows that general anesthesia in the elderly contributes to dementia, and it will increase the likelihood of failing that same-day discharge. We like short-acting spinal anesthetics, avoiding narcotics, and then if a patient doesn't want to be awake, we can sedate them using a medication called propofol. The fourth part of the secret sauce is bleeding management. Intraoperatively, we like to keep blood pressure low, which means less blood loss during the surgery. We carefully cauterize bleeding blood vessels using electrocautery. We use a medication called tranexamic acid, which helps stabilize clots once they form. And there are a lot of studies that show it works by mouth, intravenously, even topically. This is a great medication that's really changed how we manage bleeding after surgery. Our transfusion rate went essentially to 0 once we started using tranexamic acid. Fifth part of the secret sauce is our local anesthetic injections. For hips, we use one that has the acronym REC, which stands for ropivacaine, epinephrine, clonidine, and ketorolac. Ropivacaine is a local anesthetic. Epinephrine makes that local anesthetic work a little bit longer. Ketorolac's an anti-inflammatory. There are other options for a local anesthesia injection. There's a company called OnQ that makes pain pumps. There are some other long-acting local anesthetics out there like Exparel. Our studies have shown that they don't work any better than what the REC does. And then the sixth part of the secret sauce is the post-surgery details, kind of a catch-all. Our recovery room pain management approach includes using oral pain medications rather than IV narcotics for managing pain. There's less nausea associated with oral medications. We follow our patients' urinary retention with post-void checks, just like we did before the surgery. We have physical therapy on site as well. Unfortunately, insurance companies don't see the value of this, but it is incredibly valuable to have an on-site physical therapist. We also arrange home physical therapy for all of our patients post-discharge. Those therapists are our eyes and our ears, helping our patients stay safe at home. And then all of our patients get a phone call from the nurse at the joint replacement center or at the ambulatory surgery center to check on them. Okay, so the fourth ingredient, fourth of 4, for a smooth discharge process is your discharge plan. And that's a helper at home. Ideally someone who loves you, a family member, not just a hired gun who's going to help you out, because that person is going to be your coach, they're going to provide accountability, they're going to encourage you. They help you manage your medications because they have a clear head and you might not. They're a gopher. They're going to run errands for you. They might run to the pharmacy. They might help with meals. They're your driver to your first post-op visit. Very, very helpful, and they just keep you out of trouble. So in summary, you should have the right physician guide to take you through a hip replacement operation. You'll find that the best surgeons surround themselves with the best people. You should also carefully navigate those competing forces that I mentioned, the insurance payers, the implant company, marketing, and surgeons. Don't rely on advertisements. Thanks for your attention.
Thank you, Dr. Dearborn. We do have some questions. The first question is, how long after a hip replacement might somebody be able to drive?
After hip replacement, our patients can resume driving in about 2 weeks. Sometimes if the surgery was on the right leg, the gas pedal and the brake leg, sometimes we'll delay 3 weeks. I like to see them in the office before I give them the thumbs up to drive.
Okay, great. The next question we have is, why might someone have more pain after a hip replacement than another?
Well, that's a really good question. Some patients have a different pain tolerance. They experience pain differently than somebody else. Some are much more stoic. So there's the individual pain tolerance. The second is the medications that are used. Some medications are stronger than others. Some of those stronger medications produce side effects. So a patient might have to use a weaker pain medication to mitigate the side effect, and then they might have more pain because the medication they're taking is less effective. Okay,
and our last question is, I live alone with no family members in the area. Are there options for me?
There certainly are. We try not to send our patients to rehab facilities, but if you live alone, you don't have any family, you don't have any friends, which, is a sad situation. But if that's where you are, then after the discharge from a hospital setting, you could go to a rehab facility for a week or two until you're functional enough to operate completely on your own. But we do emphasize the importance of trying to find some help at home, because your house, your bed, your food is going to be the most comfortable place for you to be after a hip replacement.
Okay, thank you. This does conclude our program. Thank you, Dr. Dearborn, for this insightful presentation, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.